I've been handed over a paper and which basically outlines 8 points which need to be covered today evening. The first one is, of course, current heart failure scenario and, of course, the role of guideline-directed medical therapy. So this was a beautiful paper, but I will just come down to the conclusion. So in this contempt, I'll just read out the headline, then make few comments. In this contemporary outpatient heart failure with reduced ejection fraction Italian registry, very high percentage, all the four pillars of heart failure were actually achieved in a majority of the patients, which is quite creditable. When we look at Indian scenario, it's quite the reverse. And I find very few patients actually on all four pillars. And of course, what are the strategies? What hasn't been mentioned here is how many percentage of patients actually reach full dose of ARNI, meaning 200 milligram twice a day. So this is a point which I would like my cardiology colleagues to answer, because I find moment you reach 200, your patients certainly look very different. So it's my goal and endeavor that at the cost of diuretics and other drugs, which I will use in minimum quantity, I would rather have every patient on ARNI at 200. And believe me, at least 45 to 50% of my patients do attain 200 milligram twice a day. Now, should we have the other participants to make comments on this so that we have one topic covered completely? Dr. Dilip, what do you think?
Yeah. So we can discuss in just after trial which is presented.
So before we go to the next topic, let's cover this.
It's a very pertinent point, I think, Dr. Kaushal, about the situation of heart failure medication and the penetration of all the four drugs with proper doses in Indian context is, what we see is around, when it comes to ARNI, one of the registry data showed around 10% only the patients who were destined to have these drugs, only 10% were having these drugs in proper doses. So we can ask the opinion of our panelist, Dr. Nishant. Are you there?
Dr. Yes, sir. Yes,
sir. Dr. Nishant. So what do you feel? How can we improve the situation in India? Like, how can we spread the awareness, and is there any genuine reason why we are not catching up? And still, you see, the scenario is not very rosy even in Western world. But in India, the situation is, really it needs a lot of intervention work. So what's your opinion on that?
So I think with the proper education of physicians and these kind of seminars and CMEs, we have to spread this message that the guideline-directed medical therapy, all four pillars should be started as soon as possible, and their dose should be adequately escalated every 2 weeks till they reach the target dose, because the mortality and the morbidity of the patient differs with different doses. Although we find it sometimes difficult when the blood pressure is in 90s, that is the main hindrance to increase the dosage of ARNI. And that's how most of our patients who are having dizziness or postural symptoms, postural dizziness, we are not able to increase the dose sometimes. But many patients over a period of time, sometimes over a period of 3 to 6 months, the blood pressure rises as the ejection fraction improves, and then you can further escalate the dose to 200 milligram twice.
Yes, I think we have a Trivandrum Heart Failure Registry. We have Medanta Heart Failure Registry, where we got some insights about the actual picture of heart failure medication in those patients who are coming to these tertiary care hospitals. And, also from the kind of community experience, it's around 10 to 20% in tertiary care hospitals and less than 10 in general, practicing cardiologist. So we can move on to the next presentation, and that is very correct. I think 200 milligram twice daily, if we see among those patients who are getting ARNI, then maybe only 10% would be getting a 200 milligram twice daily, what we have seen the practice pattern in India. So I really got very kind of excited when you told that you keep your 50% of patients at 200 milligram twice daily. it's a very, very good sign. Yeah.
Simply because I'm quite convinced role of furosemide and other diuretics is very good only in the acute left ventricular failure management.
Yeah.
But in the long term or chronic situation, I think there is virtually zero role for a furosemide type of drug, and dapagliflozin itself also acts like a small diuretic. So in my own practice, we don't use furosemide or any of such drugs in the long term.
Absolutely. And they can also be counterproductive. They can also cause renal dysfunction. So
Absolutely correct.
Sometimes dehydration can cause renal dysfunction. So
the other thing I would like to have comment before I close this chapter is frequently I have I've gone to bisoprolol from 5 BD to 2.5 BD and even on a rare occasion 1.25 milligram twice a day, but got the ARNI to 200. Now, I am not sure whether it's a good practice, but I am convinced my patients appear to be better when they are on a smaller dose of bisoprolol, but on full dose of ARNI. I would like to actually have one sentences from each of you because it will help all of us.
Yeah, Dr. Kalyan Raman, can you, give your inputs on Dr. Kaushal's idea of having ARNI full dose at the cost of a little lower dose of bisoprolol, obviously no diuretic like loop diuretics. Dr. Nishant, what I feel it's a correct practice because bisoprolol in all the doses, it's not like the achieved dose they have shown benefit, but even at 2.5, 5 milligram, 7.5 milligram, 10 milligram, all across these doses, they have got benefit with a reduction in primary endpoints. So it's not a kind of not at all a bad idea. Rather, it's a good idea to keep ARNI at the highest dose, maximum tolerable dose, and keep bisoprolol around 2.55. That's a fairly good idea.